Start.
Okay. All right. My name is Stephen Lin. I'm a professor in radiation oncology at MD Anderson Cancer Center. So today I'm going to present this poster on immune activation of plinabulin to enhance anti-tumor responses, combining radiation and immune checkpoint blockade. So the purpose for the study is to look at whether dendritic cell activation along with radiation, which is a very effective antigen-presenting modality, is to whether that can enhance and convert patients who are refractory to immune checkpoint blockade to patients who are refractory after therapy. And so this is actually a clinical trial, a phase 1 clinical trial that actually targets these patients who have been resistant to immunotherapy to then in multiple disease sites, not confined to one particular disease, but in multiple diseases, to then combine radiation with plinabulin along with continuation of immune checkpoint blockade to see if we can actually convert and obtain responses. And how we came up with that rationale is first was actually from the preclinical models. We actually hypothesized that because plinabulin is a very effective dendritic cell activator, that if we actually a treatment to liberate antigens, potentially that would be a good synergy with a drug that can potentially activate dendritic cells. So we had to show that in preclinical models, first in vitro, as well as in vivo in animals. So in vitro, well, we demonstrated that the order by which you activate dendritic cells and radiation stimulation is very important. So if you actually do radiation after plinabulin treatment, you actually do not get dendritic cell activation. However, if you actually do radiation before these plinabulin treatment, you actually see very clear CD80-86 stimulation, which suggests activation of dendritic cells. We also see that through that process of dendritic cell activation, we do mixed lymphocyte reaction experiments. You see that only in those activated dendritic cells you see actually active proliferation of T cells in vitro. So with that kind of schema of actually treating with radiation first for 3 to 6 hours prior to treatment with plinabulin, we then adopted an animal model to look at it's kind of a dual tumor model where you actually implant tumors on one side, but then also implant tumor on the contralateral side. We radiated one side of the tumor, but then also look at the treatment response in the opposite side of the tumor, as well as the tumor that's actually radiated. What you found very clearly is that if you look at the different arms, radiation alone, PD-1 plus radiation, or the triple combination, this is where you see actually only in the triple combination group do you see actually a much better, not only the primary tumor response in the tumor that's radiated, but more importantly is also the contralateral tumor or the metastatic tumor, where you see actually also a much better response, only in the triple combination, but not in the doublet combination therapy. What we found is actually if you harvest the tumor from these animals, you can see that really it's the triple combination where you see a much greater dendritic cell activation, but more importantly is also greater immune infiltration into not only the primary tumor, but also including the non-radiated contralateral tumor, suggesting you generated a much better systemic response as a result of the triple combination approach. So with that preclinical data, we were very enthusiastic and very excited about doing this clinical trial, where we have enrolled since a couple of years ago. We have actually screened here the patients in the phase 1 study, 29 patients that were enrolled. However, because actually exclusions and et cetera, a lot of these patients are very unhealthy. These are patients who are multiply treated, multiple lines, they've been refractory to multiple therapies, including immunotherapy. Many of these patients are very unhealthy, so some patients actually, even before therapy started, they were enrolled but not participating ultimately. So ultimately, we actually have 14 patients that we're able to evaluate for responses. And here's actually just an part of the 14, 3 patients could not get to the third cycle, which is our primary endpoint, to look at the response at third cycle. Many of these patients already had developed new brain lesions. Their insurance could not support their clinical trial. And then only one patient has progressive disease after less than 1 cycle, so we cannot assess the response at the third cycle. So that's why after 2 to 14, we had 11 patients that were able to evaluate for RECIST criteria. Out of the 11, 10 patients are all treatment refractory. 1 patient was treatment naive in terms of immunotherapy naive, so we're excluded. in a final analysis. Here's the 10 patients. You can see here is that the overall response rate is 8 out of the 10, with 2 patients with progressive disease. And these are patients you can see here, renal cell carcinoma and Merkel cell carcinoma. But however, all these other diseases you can see here, many of them are renal cell carcinoma, Hodgkin's lymphoma, non-small cell lung cancer, head and neck cancer, and renal. You can see here is actually see either a stable disease or partial response in all these patients. 2 of these patients, particularly the Hodgkin's lymphoma patients, and these are again patients who are refractory to immunotherapy, were continue to actually response on therapy, and they're continue to get plinabulin and immunotherapy on trial currently. So you can see here is that here's the waterfall plot. You can see here is that the patients that have a partial response and the patient with stable disease, suggesting actually these are you get an 80% overall response rate with 3 patients with partial response on this trial. So that's a very, very exciting and promising response that you see in these patients who are heavily pretreated patients. This is just one example of a patient with Hodgkin's lymphoma with massive amount of disease in the mediastinum and in the lung, where we actually just radiated one site of the neck, which is an area of disease in the lymph node. We radiated that site to 20 gray in 5 fractions, and along with plinabulin, you see at cycle 3 a remarkable response, of course, to complete disappearance of the primary disease, but more importantly, a systemic response, immune response in this patient. What we actually looked at the overall in translational markers, including dendritic cells in the blood, as well as intratumoral markers in the dendritic cells in the blood. We were able to see that the monocytic dendritic cells, as well as plasmacytic dendritic cells, and particularly the activated ones, you see a much greater increase in patients who are responders compared to non-responders in all these markers, and as well as actually you can see the classic monocytes actually in compared to cycle 1 day 4. In cycle 1 cycle day 4, you can see here that the classic monocytes versus the inflammatory monocytes, there's a much greater increase in inflammatory monocytes in the patients who are responders compared to non-responders. You can see here from also the histogram suggesting that there's a much greater significant increase in the inflammatory monocytes in the blood of these patients. We also look at intratumorally to see whether actually there's an expanded cell types of these dendritic cells inside the tumor. Very, very much so. If you actually look at the dendritic cell, this is a type 3 dendritic cell, which are the inflammatory dendritic cells, along with monocyte-derived macrophages. You can see here, and then this is we're looking at a signature of GEF-H1, and GEF-H1 is one of the signaling moiety that plinabulin acts through. So GEF-H1 is the central signaling mechanism by which plinabulin acts to activate dendritic cells. So when we look at that signature within these in these dendritic cells within tumor, both monocytes as well as dendritic cells, you can see here in that the patients who are responders, they're intratumorally at cycle 3 day 1, you see a very much increase in these in these dendritic cells with GEF-H1 signature. But then in the patients who are not responders or progressive disease, you actually see a decrease in the dendritic cells that bears the GEF-H1 signature. You see that in dendritic cells, you also see the monocyte-derived macrophages, suggesting that we are actually seeing on-target responses in both the peripheral blood as well as actually in the intratumoral in tumor microenvironment in patients who are responders, suggesting that plinabulin is hitting the target and therefore causing this immune response and therefore the tumor response as well. So I think what we find this actually very promising, that actually we see not only a great response in these patients who are heavily pretreated, suggesting that there's actually a potential for this combination of radiation, plinabulin, and continuation PD-1 in these patients. And that going forward in the future, I think this is a promising, however early signal that we potentially can do this in more patients, particularly focus on some of these subset of patients where we see very large responses, particularly Hodgkin's lymphoma and non-small cell lung cancer, are 2 potential group of patients that we potentially can expand and hopefully compare to standard of care in the future randomized trial setting.